Hello, welcome. My name is Keri Discepolo. I am a researcher at Boston Children's Hospital in Boston, Massachusetts. And today I'm going to speak with you about Caries' experience in primary teeth of children diagnosed with Down syndrome in comparison to healthy pediatric patients in our Metro Children's Hospital. I have no disclosures and I received no funding for this research. So just to give some background information, children with Down syndrome have craniofacial abnormalities that affect their dental-alveolar complex in many ways, and ultimately can affect how and when they experience oral disease. Things related to the child's cranial base or the maxillary and mandibular misalignments can affect the airway and affect how the teeth occlude and how ultimately they will be able to care for themselves with respect to oral hygiene. You can see in this picture here, this child has an anterior open bite where the front teeth don't close over the bottom incisors. So the maxillary incisors are not occluding over the bottom incisors. With respect intraorally, these children have things like enlarged tongue, macroglossia, their tongue thrust and their muscular ability to move their tongue and with respect to mastication and things like that are all diminished. They can have a narrow palatal vault, and with that midface deficiency can cause airway issues. With respect to the teeth, they can have things like oligodontia where they're missing teeth. They may have increased spacing of teeth, and they can have delayed eruption of teeth. Periodontal disease or gum infection is pretty common with these children. The dental caries experience of Down syndrome children has been evaluated by researchers across the world, and there's been a lot of conflicting evidence published. Several studies have suggested that the Down syndrome caries experience is lower than their typically developed counterparts. Others have found that it's been equivalent. And still others have suggested that the rate is lower, but it's mitigated by risk factors such as dietary habits. Other studies have found that higher levels of strep mutans are present in Down syndrome children, while at the same time they have reduced salivary flows. So both of those things could contribute to higher disease experiences with respect to caries. They also have higher salivary IgA, which is thought to be protective against dental caries. So there are opposing scientific views. There's an absence of controlling for confounding information or having controls in the groups. There are calls for more observational studies where controls are employed. In this X-ray, you can see disease on the teeth, just for your own information. So just to review, dental caries is the most common chronic condition of childhood. It's widely been described as an inequality that occurs in higher rates disproportionately in certain cohorts of the population. Things like water fluoridation have been employed in the United States as a public health intervention to reduce the incidence of dental caries for all people, and it has shown to be successful. So our study is a case-controlled retrospective quantitative study of continuous and categorical variables. We studied children, specifically our patients in our children's hospital. And what we did was we used a chart review technique. We have Dentrix, which is a electronic dental software, and PowerChart, which is electronic medical record software. We utilize I2B2, which is a different program that can go through both of the previously mentioned programs and find information. So it was a nice way to synthesize information quickly instead of manually going through the charts. Our subjects were Down syndrome children and typically developed children who were matched for age and zip code. Zip code was a corollary for fluoride exposure and environment where they were living. The ages of the children were 24 months to 144 months, so 2 to 12 years of age. We ended up reviewing 772 charts with 440 children meeting the inclusion criteria, which allowed us for 220 match pairs. Our data collected were decayed missing filled surface, which is a corollary for disease incidence. We reviewed oral hygiene habits from the medical record notes. Gender and ethnicity were collected, and zip codes were used to allow us information about their water fluoridation status. And also it was a proxy for income. So our findings were with respect to, we compared the Down syndrome group and the typically developed group, so DS and TD. We had a total of 220 in each patient and each cohort. We found that any decay experience in the Down syndrome group was 97 patients or subjects. And in the typically developed group, we found 165 who were positive for any decay experience. What we then looked into, the numbers that you're seeing after that are DMFS calculations. And so that what that means is decayed missing filled surface averages for the groups, the different variable groups. And what we were looking for was not a significant difference, because a significant difference would tell us that one group was experiencing decay more frequently than the other. What we were looking for is no significant difference. We wanted to see if there was no significant difference between the typically developed group or the Down syndrome group. So what we found were children who were of African American or Hispanic backgrounds experienced this same disease rate had no significant difference in their disease experience between the Down syndrome group and the typically developed group. So we found that in those groups, it was more likely that Down syndrome and typically developed group would have similar disease experience. The next thing we looked at was fluoride exposure, and we looked at systemic fluoride exposure, which was from water fluoridation, and topical fluoride exposure. We also looked at brushing, if the children were brushing more frequently or not. So it was determined that children who received no topical fluoride, whether they were Down syndrome or typically developed, did not have a significant difference in disease experience. And children who had no topical fluoride and no water fluoridation also had more similar disease experience, where there was no significant difference. And those children who brushed less and were also, even though they were brushing less, they had received topical fluoride and when they did brush, and also they drank fluoridated water, we found that that group as well had no significant difference in disease experience. When we just looked at the trends as far as disease experience in each group, we saw that the Down syndrome group did typically have a lower rate of decay experience between the subgroups. So on the left, we're looking at the total possible surfaces that were available to evaluate in each group by age. And what we see, the lighter colors are the total surfaces available to evaluate, and the darker colors are the ones that are affected with disease. And so we see the trend go where the typically developed controls, the green group, experienced a higher amount of disease, but the Down syndrome group was not far behind. On the right-hand side of your screen, we see that out of 6-year molars, so this is an adult molar, and just to remind you again, the DMFS that we were recording was in the primary dentition. So the left-hand screen is with the left-handed graph is with respect to the primary dentition. The right-handed graph is with respect to the 6-year molars. It's an adult molar that comes in at around age 6 years. And what we were looking for was to see if there was any difference in that. This 6-year molar information is not collected in DMFS, and it was just another way for us to evaluate what the disease experience was. And as you see, the green group, the typically developed controls, experienced disease at a much higher rate than the Down syndrome group did. Now, if you'll remember at the beginning of the presentation, we talked about delayed eruption of 6-year molars in Down syndrome groups, so a delayed eruption of primary and permanent teeth. So some of the lagging behind in the Down syndrome group could be with respect to delayed eruption, but it might also be that the morphology of the tooth is not as prone to disease, or it could be they have protective factors. We didn't evaluate that in this study, but it's something that we are considering for future studies. When we looked at frequencies, this is an interesting kind of way to look at the disease experience. When you look between the Down syndrome group and the typically developed group, we see that the Down syndrome group obviously had a much higher frequency of 0 DMFS. So that means they had no decay. So a 0 DMFS scores means that there are no decayed missing filled surfaces in that child's mouth, so no disease. And as you move to the right, you get higher grouping of disease. And so what we see is that the Down syndrome group in the 60 and 80 range experienced a lot more disease than the typically developed group. And what that's telling us is that when the Down syndrome group experiences disease, they experience it at a very high rate. So some of our conclusions are that when we control for oral hygiene and topical fluoride use and systemic fluoride exposure, disease levels are not significantly different. So when we take away certain protective factors like exposure to fluoride, children, whether they are Down syndrome or typically developed, are going to have more consistent disease experience. They're going to have almost equivalent disease experience. We also saw that ethnicity and things with respect to social determinants of health should be considered in risk for disease. So if other studies made the conclusion that overall Down syndrome children don't experience disease at the same rate as healthy controls, we would like that a condition placed in that statement that they still have higher risk factors when they fall into certain subgroups, like those that don't utilize fluoride, don't brush very well, or maybe you're at a higher risk group because of their social status. So I think that was the main finding that we would like to share with everyone, is that although Down syndrome children do experience disease at a lesser rate, there are conditioning factors that will influence and modulate the disease experience in those groups. Some of our limitations obviously were that the study was retrospective, and given the setting in our hospital, we typically are a last resort for many families around the region. So we do see a higher incidence of disease as a bias in our population. So some of the practical implications for you that I would hope that you take home from this discussion is that children who are Down syndrome should really be encouraged to have good oral hygiene, to utilize fluoride, and obviously have a healthy diet. One of the things that we would encourage you to do as a medical provider is to really determine if the child is capable of their own self-care, or if maybe a caregiver should help perform some of the oral hygiene for the child, for up until an age that it may be necessary up until the teenage years or beyond to help provide some of this support to a Down syndrome patient. Fluoride exposure is so important. I can't stress how much it can help to prevent disease and mitigate risk of disease. So it's so important that we're brushing 2 times a day, at least if you can, and flossing at least once a day if possible. Utilizing a fluoride toothpaste is going to be so important. And obviously dietary considerations like limiting high sugar drinks at mealtime, replacing it with water, even if it's unfluoridated water, it's still going to be beneficial in the long term for preventing disease. One of the other factors with respect to Down syndrome is their ability to access oral health care. Children of Down syndrome have a greater need for dental care with some of the other things that I'm going to speak about in the next couple of slides, but obviously to prevent disease, dental disease, but also periodontal disease and maybe even some orthodontic care. They have difficulty getting expert considerations because families may not be fully aware of the need for their child to see a specialist. They may not understand that their child's at higher risk for things. So really speaking with the parents about what risk factors the child has and what types of prevention can be offered to them. Parental awareness of the need for care sometimes is diminished because the parents find it difficult to find a professional that understands how to work with their child, or maybe they aren't aware that there are specialists available to help them. Conversely, there are many professionals that don't have as much experience with Down syndrome children, and increasing the training of those professionals so they can provide information to families would obviously benefit the patients in the long run. So we recommend early, regular dental visits to the dental professional, beginning at age 12 months, ideally to 18 months. The earlier, the better, just to get the family educated and situated with a professional as early as possible will benefit the child in the long run. Professionally applied topical fluoride and fissure sealants are preventive measures that a dental professional can provide, along with early exams and episodic exams that are provided in a continual way. And you can also reinforce some of the dietary recommendations made by dental professionals by obviously reducing refined carbohydrates, avoiding processed snacks, and reducing juice intake. Some of the topical fluorides we use professionally are 5% to 2.26% sodium fluoride varnish. We have other topical fluorides that we might use professionally that are higher concentration in fluoride. But at home, we'd recommend a sodium fluoride toothpaste, a higher or lower amount of fluoride dependent on the child's ability to spit. We obviously don't want them ingesting too much fluoride. There are also fluoride rinses available commercially. They're available in the United States, and as far as around the world, I would look for a mouth rinse that at least has 0.05% sodium fluoride. We recommend 2 times a day supervised brushing, like I said, and assessing if the patient is able to care for themselves. If not, help them out, and definitely regular routine dental visits. Sometimes we even recommend more frequent dental visits, like every 3 months, just to help remove supragingival plaque that can obviously harbor pathogens that can cause periodontal disease or decay. One common finding in Down syndrome patients is periodontal disease. So that's the infection of the gums that causes reduced attachment. So the periodontal ligament holds the tooth in the bone, and what happens is the disease is produced by different bacteria in the oral cavity, and it causes inflammation in the periodontal ligament and the dentoalveolar complex, and can actually reduce the bony attachment of the teeth. And long term, it can actually lead to tooth loss. It does happen in the primary dentition to a smaller amount in Down syndrome patients, but it is more frequently seen in the adult dentition, and it leads to early tooth loss in this group. Variations in the normal immune response of individuals with Down syndrome make them more susceptible to infections overall. And their abnormalities in T cells and B cells is diminished, and there are multiple studies that correlate periodontal disease with heart disease, and I've even seen more recently some studies that correlate this inflammatory process to early onset Alzheimer's and Down syndrome. Orthodontic interventions could be really beneficial to this group of patients as well, because it can help to open up the airway, like we spoke about before, the midface deficiency and the high arch palate. The large tongue often lead to some kind of obstructive breathing in a large group of Down syndrome individuals. So getting them to an orthodontist early on in life can actually, if they're able to tolerate orthodontic care, can actually help to mitigate some of those risks for airway issues. So overall, our study talked about that Down syndrome children are at risk for dental disease, and that myself being a restorative dentist, that's my primary concern with these patients. But I would highly recommend that if you are working with a Down syndrome child or in a family who has a Down syndrome child, that you try and refer them to a dental specialist as early as possible, someone who's has advanced pediatric training or special needs training that can help to identify early risk factors in these groups. Some references and places for you to go to learn a little bit more about some of our recommendations from the American Academy of Pediatric Dentistry as far as how to treat and manage Down syndrome patients, or in our oral health policies. There are also different organizations in the United States and around the world that also provide good information for caring for Down syndrome patients. The NIH provides a lot of good resources with respect to up-to-date research and other information that can help provide informed, accurate, ethically, morally appropriate care for children with developmental disabilities and Down syndrome. These are my references. And I want to thank all of you for taking the time to listen to me, and I hope you have a good day. Thanks.